Does IV or IO improve outcomes in cardiac arrest? If it's Monday, it's magic. Hey, everybody, welcome back to Magic Monday here on the Overrun. Ed Bowder and Dan Schwester talking about new data in medicine. And today, Danny, we're going to discuss whether or not IV or IO improves outcomes in cardiac arrest. So this study that we're looking at, Danny, this came out of British Columbia, and it just looked at whether or not starting an IO or starting an IV in cardiac arrest improved outcomes, which is an interesting data set because it just kind of looked at one specific thing.
Yeah, very narrow focus study, but it was interesting and had some potentially interesting results. The overall idea was to see whether giving epinephrine intravenously, as opposed to giving it through the humeral head IO route, would contribute to better survival and better outcomes.
And as this data set kind of showed, there wasn't really too much of a difference between the IV and the IO groups. And there's a lot of kind of different things that we can discuss here, but there is some issues with all of this, as there is with any data. One of the big important things we look for in any study, right, that says further research is needed to comparing clinical outcomes of patients treated with IV and IO. So we always like that, right? This isn't a diaspora. This is one study that shows one group. In this group, 1,575 people received IVs, 537 received IOs. Now, this was a sort of an observation thing they did. It's a little bit retrospective, so this wasn't controlled. This wasn't, one group gets an IV, one group gets an IO. They did actually have a pretty good methodology here. They looked at cases with no vascular access or patients that had ROSC beforehand. So they did a very good job at saying if you have an IV or you have an IO, which is more likely to get you a return of circulation. The average patient age is in their mid-60s, which probably wasn't surprising to anybody. They had a lot of unwitnessed. They had some bystander witness and some EMS witness cardiac arrest. And then here we look at favorable neurological outcomes with the full cohort and the weighted cohort. They do talk about ROSC here and ROSC at the ED. They talk about success to the first chosen route. This is, as we said, this is a very well put together study. And their basic conclusion here, in adult out-of-hospital cardiac arrest, an IV-first approach was associated with improved odds of a favorable neurological outcome, survival discharge, ROSC in the ED compared to humeral IO. So as they're talking about this, they're essentially looking at what improves outcomes in cardiac arrest. And looking at an IV versus an IO is not necessarily sufficient, but it is an interesting conversation to have, Danny, because we've certainly had this talk for, years now, which is if I walk into a cardiac arrest, do I want to do IV or IO? What's going to be the most effective? This tends to show that just starting an IV is superior to IO, but there's a lot of variables that I don't think were effectively addressed.
Yeah, and I think they did a really good job in the study accounting for the differences in the number of humeral head IOs as opposed to IVs. I'm not a statistician, but they did regression analysis and they looked at the variables and they were able to correct for that. So one side isn't really benefiting from having more, so to speak, than the other side. That being said, it was kind of interesting that they pointed out that IV access seemed to have a better ratio of ROSC and a better survival. And if you look at it on the surface, you're like, that's interesting. But what the study didn't really get to with me was, why is that working better? And we have to look at I think we have to look at the overall physiology of cardiac arrest patients. And Ed, you love this subject. This is something you have been on for almost as long as I know you, that we don't know anything about what we're doing with cardiac arrest. And I'm going to go a little bit off that, but I'm going to say we don't know yet what works. We're still trying it out. It's like we're learning how to bake bread, right? We know we kind of got the formula down at some point. Now we don't know. We're just trying to figure out how to tweak it to make it work right. And this is one of those studies that would help us with that. IV versus IO, if you think about it from a common sense perspective, IV is already in the vasculature. It's already in the central circulation. It's where these drugs are designed to work. Probably better. There is, especially, I liked how they talked about in the limitations of IO access for cardiac arrest, that they talked about, especially with drugs that are lipophilic, like fat that are fat soluble, that the bone marrow tends to be able to kind of suck that up and leach kind of that out so it doesn't get into the system all the way. And that would be something that we would probably want to study more, because if that's having that effect, that's certainly going to affect survival outcomes. That being said, it really looks like, to me, that we're starting to congeal around this idea of different arrests, different foci, and however we do it, we have to start thinking of it. Because if it's a witnessed arrest with a shockable rhythm, we know now excellent compressions, early defibrillation right away. Those are the first two things. After that, it seems like if you can get IV access and get a dose of epinephrine on board, that's probably the best result for your patient. If not, IO is okay, but doesn't give you the bump that IV epi would do. For a non-shockable arrest, again, great compressions, getting vascular access, getting that epinephrine on board, and epi's not lipophilic, so we probably don't have a problem with the bone marrow sucking up some of the drug. I just wanted to put that out there before somebody goes, "Buh, Dan, you really didn't understand the pharmacology." Buh, but, whatever. I think it's interesting, but I think we're also getting back to common sense, right? As these patients, one of the figures they said, I think the median time to my administration was about 9 minutes, right? And
about 9 minutes,
yeah. And to me, that seems pretty long. And I think at that point, 9 minutes into a resuscitation, I think you got a pretty acidotic patient. My question is, if we're waiting to give these meds at that point when they're so physiologically deranged, are we going to get a result? We probably won't. If we want these things to work, we want them up front, right?
No, I think that's probably right. And one of the things that's interesting with extracellular acidosis and intracellular acidosis and all this and cardiac arrest is probably if someone has been acidotic and they're down to a pH like 6.8, then it probably doesn't really have any effect on the actual circulating drugs that are within the vasculature. That said, though, in this study, we're starting an IV, we're starting an IO, and we're getting the first round of epi in between. It was around 9 minutes. It was 9 minutes for the IV group and 9.3 minutes for the IO group. So, we're getting vascular access, we're getting epinephrine to these patients. Those of you who are interested, on overrunems.com, you can see a blog I recently wrote about essentially the futility of epinephrine in cardiac arrest. We've been using this for decades now, and it's shown no improvement in outcomes. Now, there's plenty of variables, right? Maybe giving IV epinephrine less than 9 minutes into the arrest is beneficial. But at some point when it comes to administering drugs, I feel like we start to split hairs at some point, where right now, when we look at protocols and algorithms for cardiac arrest, the idea when AHA and Red Cross put out all this stuff was that it was to be universal for everybody. And now, just like everything else in medicine, we're learning that there might be specific individual therapies that need to apply to certain patients. So it could be that maybe IV is the superior vascular access in cardiac arrest, but you have to do it within, say, 5 minutes of the patient dropping, which is just not realistic for EMS in most settings, right? So I have difficulty accepting that just the IV versus the IO changes outcomes in cardiac arrest. Like we talked about earlier, I can see if you're establishing an IO and you're doing that push to try and get that pocket within the bone marrow. I can see that drugs might get stuck in that medullary cavity, so they don't actually metabolize the way that we want them to. So maybe giving them IV, still hitting that, bypassing that first pass metabolism, actually getting the drug into central circulation. Maybe that is very important, and maybe that's done better through vascular access. But again, if we're doing it in 9 minutes, so in this study, it talked about the first access was 6 minutes from patient arrival, which is another thing, right? When we get on scene, what was happening in that 6 minutes? And I don't want to, parse things too finely or split too many hairs, but in that 6 minutes, were we deciding whether the patient was viable? Were we deciding that, do we do airway first? What do we do first? And I think we train to go in and do compressions, and then maybe we kind of are like, all right, well, let's see what happens after we do a round, right? Because 6 minutes to an IV and 9 minutes to epinephrine, that timeline with those 3-minute gaps, that says to me that we're working through ACLS to try and figure out if this patient is viable or not. So we might require a sort of seed change in the way that we approach these patients, assuming that, you know what, this one is viable, let's go in and just do it. And maybe we have to come to a point where we actually start delineating, witness, non-witness, asystolic and shockable rhythms. And maybe through a shockable rhythm algorithm, once you get down to a certain point, IV is preferred over IO. And again, maybe we have to start dealing with timelines too, right? Maybe it's like, all right, well, if you have something where the patient's been down for 5 minutes. All right, well, in 5 minutes, then we're going to do, almost your compulsory 3 rounds of CPR, get your epinephrine in, get your line in. But if they've been down for 10 minutes, then maybe it's a different approach to resuscitation.
Absolutely. I think that one of the interesting things that I took from the study was the time to access, whether it was IV or humoral IO, was pretty close. So that kind of throws, the idea of the IO being rapid access. We have this idea that like, oh, we're going to fumble around and have trouble finding an IV. So the IO is we're much more likely to get it seated on the first try. We don't have to fumble around. And that this study did not really show a huge time advantage to starting the IO as opposed to getting an IV. So it might be something to think about. And I think you're right. I think we're moving into an era, and you see this in other specialties. Oncology is a perfect example, how we've really moved.
Cancer therapy is gene treatment at this point. It
really is, right?
It's not chemotherapy, it's Danny therapy.
It's really like, well, this is what your body is made up of. Here's the structure, here's your genome. This is the glitch here, and we're going to fix that and you'll be fine.
Yeah, my oncologists know the mutation that I have, and that's like all of my treatment is specialized toward that. And you're right. I think that we are moving to kind of a hyper specialized type of care. Obviously, pre-hospitally, we're not going to know this patient's genetic makeup. We're not going to know everything to that extent, but we certainly, I think, can at least establish protocols or some kind of guideline where, all right, instead of, asystolic versus fibrillatory arrest or shockable versus non-shockable, however you want to categorize them, maybe it's better that you have, all right, this is the algorithm for a shockable rhythm with less than 10 minutes of downtime. This is the algorithm for shockable rhythm with more than 10 minutes of downtime. And I think what's going to slow that progress is that it's going to involve people having to write protocols and actually read data, which is very labor intensive, which is why we have the Monday Afternoon Journal Club here on the Overrun.
Right, and that's why they're going to have to think. Not going to be where the recipe in the cookbook is going to fit for everybody necessarily. We are going to have to be clinicians, tailor treatment to the goals of what we're trying to do for the patient, and go from there. And I think that's probably where all this convolution and all this confusion about resuscitation science is going. It's not a one step checklist that fits everybody. You're gonna have to take into account time of arrest, presentation of arrest, history, things like that. Maybe even, we do it with hemorrhagic and ischemic strokes. We treat them differently. Occlusive myocardial infarction and non-occlusive myocardial infarction, we're doing that. CHF with sympathetic crashing pulmonary edema, or CHF, which is just poor fluid management with edema and tiredness and things like that. We treat that differently. This is going to be no different. I think we're really moving into an era where we're tailoring care for the person based on the presentation, and that's what's going to give us our best chance for improving survival.
No, I think that's probably right. So going through all this data, again, we like to talk about whether or not something is practice changing. Danny, I don't know if this is practice changing for me. I think it's an interesting observation to make. My practice for a while now has been frontline iGel and IO. this is probably something I'm going to consider going into my next cardiac arrests. If I have a shockable rhythm, maybe starting an IO and then moving to an IV, similar to like you start with an iGel and move to an ET tube in certain populations, or maybe just going right for the IV. But is this something that you see as practice changing?
Not so much maybe changing, more tweaking. I kind of have my thing when I go on a cardiac arrest, what I want to see when I get there, what I have to make sure is working. In that case, I'm going to reordering my priorities, right? I'm going to make sure that we're getting good compressions done. Either that's mechanical, where we don't have to necessarily worry about it, besides making sure that the glucose or the auto pulse is in the right place. If it's manual compressions, making sure we get fresh compressors, make sure we have people that are doing it appropriately at a good rate and depth. The second thing is going to be, if it's a shockable rhythm, everything in the world is leading up to getting that shock. So good compressions, priming the pump, getting the defibrillation, getting hands right back on the chest and moving on to the next thing. If it's a non-shockable rhythm, we can skip over, obviously, the shocking part and move into the third part, which is access. I want good access. I want reliable access. And if they have a honking AC or they have a really good EJ, that might be the go-to. If we can't get any access or they just have poor vascular condition, we're going to go to an IO, but it'll be a humeral head over a tibial. And finally, at the bottom is going to be airway. I think we've historically focused on the airway first, and it's really hard to break that ABC mnemonic in your head. But I think we have to, and we have to hold off on that advanced airway until those things have been accomplished, then focus on getting an advanced airway and then continuing the resus. So that's what I'm going to do.
And just remember, we've always taught that even though it is ABC in the setting of cardiac arrest, your cardiac problem comes first. So there is still some extant data that actually doing compressions will exchange some oxygen. You put a nasal cannula at 15 liters, you can still cause some nitrogen washout and actually get that patient oxygenated. We're not really sure if IV or IO works better. I think this has been a really important and interesting conversation, but let us know what you guys think. Be sure to comment down below here on YouTube, subscribe to the Overrun podcast on Spotify and wherever else you get the podcast. Check out the rest of the stuff we have up on YouTube. Every day there is more and more content here at the Overrun.
Help us with the algorithm, please.
Absolutely. Every like and click gives us some help on the algorithm. It gets us out there. It gets us information to more people. For the Overrun, Ed Bowder, Dan Schwester, check out overrunems.com and check out all of our stories on ems1.com as well. For the Monday Afternoon Journal Club, we will see you all next week.